Good afternoon, everyone.
Good afternoon.
Okay, we're going to get started. I'm going to really be brief and turn it over to the individual at CJCC who's really put this program together. I'm Manon Butler, the Executive Director of the Criminal Justice Coordinating Council, and I'm pleased that you are here with us this afternoon to really focus on mental health and the current state of care for youth in the District of Columbia. The thing that's so important about this gathering is there are a couple of things. One is that annually CJCC convenes a Juvenile Justice Summit. We ask our participants, and how many of you participated in our Juvenile Justice Summit this summer? A few of you that are here, actually many of you that are here. We ask our participants to advise us, provide guidance on those issues that are incredibly important to you and the work that you do. Focusing on mental health and where we are in the District of Columbia was a common theme that emerged when we were requesting feedback from partners. And so, true to form, our goal was to put together a workshop that responded to the request of our partners, thus the session today. You have a rich set of this is going to be a rich session, and you have a wealth of speakers and expertise here, but you also are subject matter experts, and so we really will look forward to your participation today and sharing and shedding light on the issues that we experience in the District of Columbia, but the path forward. Many of us know problems. We really want to walk away and start coming up collectively with ideas as well as paths forward so that we are addressing the range of issues that our young people are facing as it pertains to mental health in the District of Columbia. I want to take this time to acknowledge a few folks. First, behind me to my left, Diamond Van, who is the person who is responsible for pulling this together. She is just an incredible resource in the District of Columbia and an incredible member of our CJCC team. And so she will be moderating today. And so we're really in for a treat. I also would ask that the CJCC staff that are in the back and around the room, if you could raise your hand or stand. This is a team affair, you guys, and so you get all of us. And so I want to acknowledge the team for always being willing and able and doing such a great job of coming together to put these types of events on. I want to thank you, for your participation. For those who don't know, just a quick housekeeping note. Restrooms are through these doors, the double doors as you're going through the where the bank of elevators are, and they will be through that door. But if you need some additional information how to get to the restrooms, we'll help you out there. I'm looking forward, I'll be here for a segment of this afternoon. I'm looking forward to a robust discussion. We have an incredible set of speakers lined up, and we're really thankful for that. And without further ado, I'm going to turn the mic over to Diamond Van, our juvenile justice specialist.
Good afternoon. Thank you, Manon, for that warm welcome. And thank you all for coming and taking time out of your busy schedule to talk about something that's really important to our juveniles in the district. So in true CJCC fashion, we start with a survey. So everyone break out your clicker. Looks a little bit like that one up there. You should have it. It's on a blue string. Everyone have it? You ready? Okay, so we have a few questions for you. Our first question is, what ward do you live in? Use the number that is on your clicker to correspond to the ward or the state that you live in. I'm going to give you about 5 more seconds. Ward or state that you live in. Everybody answered? So in true fashion, Maryland is repping. However, Ward 7, thank you for showing up, as well as Ward 4. You didn't. So we generally use this information to look at who's coming, and then who we should encourage to come a little more often so we can make sure all voices are heard. What age group are you in? You can tell the truth, no one's looking. There should be a couple of you. Some of you haven't answered. I see the number at the bottom. Thank you. So 31 to 40 is our largest group. Thank you all so much for coming. Which best describes your role? Are you a government official, a mental health services provider, a community advocate, a social services provider, a concerned citizen, or you just came to hear? Make your choice, please. Okay. So most of you are government officials. I hope you take away something today that you didn't come with. Last but certainly not least, in your opinion, how easy is it for district youth to find the mental health services they need? Very easy, easy, unsure, difficult, very difficult. So the majority of you think it is difficult for our young people to find the services they need. And after today, hopefully it won't be as difficult. Hopefully you will network with folks here. Our panelists will be able to share information with you that will help you navigate that system a little bit better for our young people. Thank you all for participating. Please give the CJCC staff person your clicker. We will stalk you for your clicker. Thank you. So to keep us moving this afternoon and in an interest of time, I would like to introduce our special guest. I truly believe in, and we here at CJCC love to hear from the people that we are serving. So one of the things that we have for you today is a young person who can speak to this better than I ever could. Shanicia Raidford is a young adult ally with the Department of Behavioral Health. She is extremely passionate about helping other people and helping people navigate through the mental health system. She's currently in a program to get certified to work with people who are experiencing mental health difficulties. Without further ado, can you please help me welcome Shanicia Raidford.
Good afternoon, everyone.
Good afternoon.
I would just like to say I'm excited to be here, and I've been with Department of Behavioral Health Youth Council for over a year now, and it's really opened up lots of doors for me. Before I was introduced to the Youth Council, I was in high school. I was a high schooler dealing with mental illness, and those, 11 to 12 years was one of the most difficult years. Thank you. I would say they were very difficult. And being in a school where we didn't really have many mental health resources, it didn't help. So I eventually got to a core service provider who told me about Department of Behavioral Health Summit. And so by that time, I'd had about 3 hospitalizations in a span of maybe 1 to 2 years. So I had ideas. I had, questions. And I really had ideas about how, youth or just people suffering with mental health in general should be treated and how they should be getting services. So they were just like, hey, do you want to come? And I was just like, sure. And I really didn't know what to expect when I got there. So when I got there, I just asked a lot of questions, and I guess, I spoke up. And so while I was there, two of the youth council members had said, hey, we have, youth council, it's every week, every Wednesday night. And so I was like, sure, I'll come. And so from then on, I started coming every Wednesday night, and a whole lot of doors opened up, and a whole lot of great people from DBH kind of just opened their arms to me and gave me a whole lot of opportunities. So it's been really great. I've been able to be certified as a certified youth peer specialist there. And what that is just helping others in the community engage into their mental health treatment and be that kind of bridge between mental health providers and their clients or consumers. So I've been on the side of where I don't really see like, clients or consumers like face to face, but I've been doing presentations, of how to engage people. And so being there is giving me a voice to really, say, hey, maybe this is what can help and this is what can be better. And I've been to conferences. I never even knew that, people had like mental health conferences. So I've been to conferences in Florida, and it's just been a whole lot of like first times for me there. I can say that their goal is to help, transition age youth, transition from children to adults. And I can really say that they've helped. They have Wayne's Place, and they actually, when you get there, like, what kind of services do you need? And so they're really trying to help you get back, get on your feet and, help yourself. I can say, really just being there it was kind of like a glimmer of light, hey, like, I'm not just this person, dealing with mental illness, I don't really know the services I get, I thought, like, I just had to deal with them. I didn't know how to say, this could work to my service providers. And I think that's, like, a lot of youth feel that way. And in schools as well, like, they think that teachers only care about the grades. So if you're doing well in school, then, nothing else matters. So being able to really have a place or have it set up that we can give our voices to help others. Like, hey, to other systems. Like, hey, maybe this will work. This may not work. Being able to, come up with those truths that, hey, just because you're in school and you're doing well, other things matter. And as far as how to engage others in treatment, maybe you should. It helps to really kind of focus on, meeting someone. Like, if you were just meeting someone for the first time, you wouldn't just kind of like, tell them like, hey, this is what you need to do. Like, focus on like, something personable. Like, hey, I like your shoes, where you went to, kind of like, get to know them. So it's really given me and others a voice to say what can help and what can't help. So thank you.
Thank you, Shanika. Does anyone have any questions for her before she takes her seat? Okay, thank you. Without further ado, let me introduce our moderator for today. Dr. Malcolm Woodland is a PhD, the acting chief psychologist, and the associate deputy director of Court Social Services Division of the DC Superior Court. He has worked with juvenile justice for several years, conducting evaluations, providing psychological treatment, and expert testimony. He has research articles which are pretty phenomenal. I've read several of them, and we talk about them in our Restorative Justice work group. He is an advocate, a zealous advocate for youth in the District of Columbia. And without further ado, our moderator, Dr. Woodland.
See, can I use this? Should I use this? I can't use that. Good afternoon.
Good afternoon.
All right. Thank you so much for having us here today. Really excited to be a part of this panel and take part in this really important discussion. Thank you. Again, my name is Malcolm Woodland. I am the acting chief psychologist over just across the street at the Superior Court of the District of Columbia. And before I get started and show a few slides, I want to take a moment to introduce my distinguished panelists. First, Dr. Megan Sullivan. She is the project director for the DC Social, Emotional, and Early Development Project at the DC Department of Behavioral Health. Prior to working at the DCC project, Dr. Sullivan spent over 10 years working with several DBH prevention, early intervention, and treatment programs focusing on children. Specifically, Dr. Sullivan provided direct service within the DBH school mental health program and was the program evaluator for the school mental health program, Primary Project, and Healthy Futures. Let's welcome Dr. Sullivan. Also on our panel, we have Ms. Leslie Ann Bynum. She is the project director for the Department of Behavioral Health's Transition Age Youth System of Care Project, otherwise known as Our Time. Ms. Bynum is responsible for overseeing the project and assures that youth and young adults of transition age, that's between 16 and 25 years old, are offered, have access to, and receive developmentally appropriate TAY services, support, and programming that are specifically designed to prepare them to transition into adult roles. Ms. Bynum has over 20 years of professional experience devoted to program management and development on a local, state, and national level, as well as for the U.S. military. Originally from Brooklyn, New York, BK. So it's always Brooklyn people in the room. I lived there for a while, so I understand that process. Ms. Bynum received her master's degree in clinical counseling psychology from Marymount University in Arlington, Virginia. And let's welcome Ms. Bynum. And last but certainly not least, we have Ms. Brittany Dash-Glove, who was raised in Orangeburg, South Carolina State, yes indeed, in a poverty-stricken area with very few opportunities for growth. She was determined to make a difference and overcome the obstacles that life presented. This inspired her to pursue her bachelor's degree in social work from Johnson C. Smith University and master's degree in social work from the University of South Carolina. She later obtained her LGSW, where she later obtained her LGSW. From that moment, she has built a career working with at-risk youth and families with trauma histories. Ms. Dash has a variety of experiences in working in the field of social work. Her skill set includes individual and group therapy in group homes, schools, and agency-based settings. At the present, she is a trained functional family therapist for the Department of Human Services. As an FFT therapist, she interviews and conducts ongoing assessments of youth and their families, targets changeable risk factors for intervention, identifies and develops and implements appropriate cognitive and behavioral intervention strategies that are sensitive to the unique characteristics of each family member within the guidelines of the FFT community resource. Her most significant reward as a therapist is seeing her clients achieve goals and accomplish beyond their expectations. Let's welcome Ms. Dash-Glove. So thank you all. As you see, we have a very distinguished panel with a very diverse professional background. So I'm sure you will be able to get a lot of questions that I'm sure we do have answered today. So, as I said, my name is Malcolm Woodland. I am from the Superior Court of the District of Columbia, and in particular, a small clinic there called the Child Guidance Clinic. Has anyone ever heard of the Child Guidance Clinic? One, two, a couple people. Most of y'all know me. That's why, that's why you know of the Child Guidance Clinic. We are a small clinic in the Superior Court. We work with young people who are going through the adjudication process. So if you're not working with kids who are being adjudicated, you probably haven't heard as much about us, but you may have seen our reports in passing. Much of what we do are the psychological evaluations, psychoeducational competency evaluations for young people in the District of Columbia. But we'll get into that a little bit more. But we are housed in, yep, here we are. So we are housed in the Court Social Services Division. Now, has anyone ever heard of Court Social Services?
Yes.
And I know we have some court social services employees here. Can I see by raise of hands who in here is from the Court Social Services Division? All right, so let's give these people a round of applause.
Yes.
And I even heard someone out there say a salute, and I think they definitely deserve it. And I get to walk in, I'm sorry, I have a little preacher in me. And the person's telling me come back, so let me come back this way. So I certainly want to give them a hand because they do a ton of work in this city. And it's that thankless kind of work, right? It's the work that needs to be done, that a lot of people can't do, won't do, and that you're rarely thanked for. So now I'm going to talk about them a little bit. And you'll notice this really, really busy slide that I have. And as I put it together, I said, well, it's a busy slide because Court Social Services Division are busy people, right? The folk, they're doing a lot. So what you see is the building across the street, right there in the middle. You might notice it. That's where the Court Social Services Division, that's the main offices in Building B of the Superior Court of the District of Columbia. And what you see around it are our Balance and Restorative Justice Centers, right? So these are community-based drop-in centers that young people who are on probation can attend, right? And in these drop-in centers, we have a variety of services. They can receive therapy. They can receive therapy from community-based workers. They receive tutoring. The probation officers, in addition to monitoring these young people, attending their court hearings, their home visits, going to their school visits, actually cook meals for them at the Balance and Restorative Justice Center. So these are the different centers we have. On the right is our Balance and Restorative Justice Center, the right top for the status offenders. Those are young people in the city who are arrested for things that adults can't be arrested for, right? That includes running away, not going to school. So they have their own Balance and Restorative Justice Center. Just below that, on the bottom right-hand side, is our Q Street barge. And that is solely for young women. So that's for the LOPS unit. And only young women go to that barge, and they have programming specifically for young women. Just on to the left of that is our barge unit in Southwest. That's just across the street from National Stadium. Then you have our barge unit in Northeast, which is just around the corner from Rhode Island Avenue Metro. And then our barge in Southeast, which is at the Big Chair on V Street. So what you see that we've been able to do is take juvenile justice out of downtown, right? This big place that you have to come to downtown, and really bring it into the communities. And not only bring it into the communities in terms of, you know, typical, I guess what I would call non-rehabilitative juvenile justice, but really trying to be a resource in these communities. So what is balance and restorative justice? And Ms. Van just talked a little bit about that. It's something that the city is really just starting to, I think, emerge. I know the OAG office has been doing a wonderful job thinking about balance and restorative justice and how they can work in that capacity with young people who are being charged. CJCC is doing an excellent job of pulling us together and really leading this effort about how we can think about a different model for engaging young people in the District of Columbia who have been adjudicated. And so balance and restorative justice, really in essence, is a philosophy. It involves a philosophy change, not only for the community, but for the young people who are out here offending in some cases, right? And that change is we begin to think about and push young people to think about what they've taken from the community in terms of offending and how they can return, how they can give back to their community. As a part of our balance and restorative justice centers, we've also been able to find new ways of problem solving, right? So what we have our young people do, and all of our probation officers have been trained in this, is having young people engage through what's called a circle, right? And these young people sit in a circle and they can problem solve in the circle. They can talk about what's been going on in their everyday lives in the circle. And it's really become a very unique way for young people to engage with each other in a format that's non-confrontational and really involves them being pulled together and talking and having a person who can help them kind of engage and talk about what's been going on. Also, having a barge has really forced our probation officers to, I think, be not solely punitive, even though sometimes I guess it's appropriate to be punitive, but it really focuses them to think about trauma, mental health, and circumstance, right? And I think the most unique thing about the way balance and restorative justice is done in the Court Social Services Division in the District of Columbia is actually having a barge center, right? There's no other place that I've seen across the United States that has a barge center. A barge center generally is not coupled with balance and restorative justice. And what that means for the District of Columbia is that there's a place that this balance and restorative justice can happen. There's a place where the circle happens. There's a place where kids come and they're engaged by their therapists, they're engaged by their tutors, they're engaged by everyone who's sitting in this room who has interest in helping these young people. There's a space where that can actually happen. And we know how it is in the District of Columbia and in so many cities. Space is at a premium, right? So to have a space where these services can happen, where this language can occur, where these philosophies can take hold, I think is really important and impressive. And to me often shows how the District of Columbia, and I don't think we get enough credit for this, is really ahead of a lot of different jurisdictions in terms of the work that we're doing and how we engage our young people. So, in true fashion, I am by nature a researcher and statistician, also a clinician, but in every presentation that I give, I'm always going to talk numbers, right? So I want to share with you some of the numbers. So, and I'll tell you briefly before I get into them how we get these numbers. So every young person who's arrested in the District of Columbia receives a mental health screen, right? So when they walk in the door, we want to be able to identify what's going on with this young person, what are the germane issues and mental health issues that we really need to be focusing on when this person walks in this door. Would this person be appropriate for our juvenile mental health court? Are there concerns around a youth being sexually trafficked? So those are all things that we ask at the basically at the very beginning. So what I've done today is kind of put some of that data together to share with you the kinds of kids or the kinds of things that are going on with the kids who are walking in our doors, okay? So what you're looking at here is a map of the District of Columbia, and the areas shaded in the darkest green are where the majority of youth who are being arrested in the District of Columbia are coming from. So you'll see they're coming from the most eastern part of the cities and the most southeastern parts of the cities. Ward 7 and 8, and then you see clusters kind of north along the Georgia Avenue corridor in Ward 4, and also over there in Southwest. And of course, as you go further and further west and across the line of the park, you see very few of our young people are coming from those neighborhoods. And then you see Maryland up there, for the Maryland people in the room. Right? You see Maryland up there, and we know that 10% of the young people who are arrested in the District of Columbia actually have an address in Maryland. So, once we identified where those young people are coming from, we wanted to get a sense of what were the dynamics in the communities that they were coming from, and probably most of them you can imagine, right? I think everyone in this room, as Ms. Butler or Ms. Van pointed out, are subject matter experts, right? And you all know the dynamics of the young people that you're working with. So we know that the vast majority of kids who come through our doors are from the lowest income, are from families with the lowest incomes in the city. That's 46%. Altogether, the two lowest income brackets, it's almost, actually it's over 7, it's about 75%. We know that the young people who are being arrested in the District of Columbia come from communities with the largest percent of adults without a high school diploma, right? That is 37% coming from, 37% coming from communities with only 23 to 32% of adults having a degree, and then 18 to 22%, and so on and so forth. This is the statistic that I think most of us may not know, and this was the one that was most concerning to me. as a mental health professional and just as kind of an individual, period. So we looked at the percentage of youth coming from communities with higher rates of violent crime, right? And what we see is that the vast majority of our kids, 39%, are coming from communities where they see 19 to 27 violent crimes per 1,000 people, right? Does anyone know, and maybe you all in the back can't see, the average rate of violent crimes per 1,000 people in communities across the United States? It's up there, but let's just have a brief discussion about that. Did anyone know that? Does anyone know that number? Right, 3.7, right? For those of you all can see it. So the average number of violent crimes that people see in a neighborhood or that people have in a neighborhood is 3.7 violent crimes per 1,000 people. Our kids are coming from communities, the vast majority of kids, over 70%, are coming from communities where they're seeing 13 to 27 violent crimes per 1,000 people. What that is, to put in numbers, is they're seeing 5 to 10 times more violence than the average person, than the average child, right? We have subject matter experts in the room. What does it mean when a kid sees violence? What's that? Who said it?
Trauma.
Trauma. What else?
They become desensitized.
They become desensitized. What else happens? How do these kids look for my school officials? How do these kids look in the classroom? How do kindergartners look who've witnessed domestic violence? They look aggressive, right? How else might they look? They can't concentrate. Exactly. How else? Catatonic in some cases, distraught, emotionally dysregulated, right? So when we're talking about a group of young people who are seeing the vast majority more violent crime, 5 to 10 times more violent crime than what we might consider normal, then we would expect some of the issues that we might see in school, certainly a number of the issues that I see by the time they get to me as adolescents, right? And they're being adjudicated. And I mean, to me, what I'm even more clear upon is, or clear of, is when you're dealing with young people, or just people in general who have the least, right? We're talking about kids who are really the most vulnerable, who are from communities with the lowest income or from families with the lowest incomes, right? And the lack of protection that comes with having a lower income, right? When they're coming from families with fewer educational opportunities and the most violence, right? We're really talking about our most vulnerable kids who are forced to have to cope and negotiate seeing some of the most difficult things for any person, especially a child, to be able to negotiate without having subsequent mental health and behavioral problems, right? And then, of course, this last one, there's no real good place to put this, but I always say I really have to address this, and this is the one place where I think the city doesn't do a good job, and the country doesn't do a good job, is addressing this disparity. These are kids who are arrested in the District of Columbia. And what it tells me is that the only kids who are arrested in the District of Columbia are African American. And you know, we talk about a lot of things in this city, but to me, this is perhaps the most glaring statistic that I've shown. And this is something that just does not get talked about enough. We really have to find a way to address the disparities around arrest, the disparities around adjudication in the city. So, what do we see with young people arrested in the District of Columbia, right? So, as you all might imagine, if they're coming from communities with the most violence, with the fewest resources, you're going to see a large number of young people who meet criteria for at least one mental health disorder. And that's what our data is showing us. When young people are walking in the door, over 50% of them are endorsing meeting criteria for at least one mental health disorder. This shows you the mental health disorders disaggregated by gender of what they're meeting. So at the top, I don't know if you all can see this. Can you all in the back? Probably not so good. You can see this? Excellent, excellent. So what you're seeing up here, this is ADHD numbers, and you'll notice that it's actually the girls who are endorsing higher numbers than the boys of ADHD, inattentive and hyperactive type, conduct disorder, ODD, and major depressive episodes. Right? So 30% of the young women who are walking in our door are endorsing having a major depressive episode. 25% are endorsing manic episodes. Social anxiety is up at 30%. And our boys are actually just a little bit lower. And we've been thinking about that too. The fact that our girls are actually endorsing much higher rates of mental health disorders. And we're trying to figure that out. And our working hypothesis is now, because what we're seeing with our girls is that once they complete probation and once they go on into adulthood, they're actually not having these mental health problems as severely as they were when they were juveniles. However, our boys, on the other hand, who are endorsing fewer mental health problems at this point, once they go into adulthood and once they get out of the system, they're actually endorsing more mental health problems at that point. So our guess is we're actually catching them at this odd place that I can't quite show you with the microphone, but it's almost like this, right? Where our girls are headed upwards and our boys are headed downwards, right? And we're catching the boys just before they're going down, and we're catching the girls just as they're coming up, right? And this is just our working hypothesis at this point. So that's why we think we're seeing those higher rates of endorsement of mental health issues coming from our girls. But really the broader story, beyond disaggregating these data, is just the heightened numbers of young people we're having, period, who are walking in our doors with mental health problems. And unfortunately, by the time I'm seeing these kids, and I don't have that number up here, but I know it off the top of my head, the average age of young people who walk into our door is 15 years and 9 months old, right? So we're catching them at 15 years and 9 months old, and these are the types of numbers that they're giving to us. So what I imagine is I would have hoped that someone would have addressed these issues long before they're getting to me at 16 years old. And by and large, that's not the case. So what you're looking at here, and this again was just like that violence statistic that really caught me, harm to self. When our young women walk in the door, 15% of them have thought about suicide. That is an astronomical number, right? 15% of the young women who have walked through our door before they have gotten there, and the question is within the last 6 weeks, right? Within the last 6 weeks, 15% of our young women have thought about hurting themselves, and 5% of our boys, which is still far too much. So, what do we do at the Child Guidance Club? Does anybody know who that is on the, somebody in here has children? Sid the science kid, exactly. My daughter loves Sid the science kid, right? So this is how we kind of think of ourselves, it's kind of science kids. So primarily what we do is assessment. Like I said, as you'll see, we may talk about it a little bit more today. The vast majority of the psychological evaluations that you see for young people who are being adjudicated, psychoeducational evaluations for those of you all who are in DCPS, competency evaluations, violence risk, psychosexuals, that's the Child Guidance Clinic. We also do some treatment for those kids who are underinsured or kids who don't have insurance, which actually isn't that many in the District of Columbia. We do the primary treatment, individual therapy, group therapy for those kids. As you might have guessed, we also do a lot of research, right? We're very interested in measurement. We may have the opportunity to talk about a measure that we developed that helped us identify young people in the city who are at risk for being trafficked. They're actually using the instrument now in Chicago as well, and maybe piloting it in Los Angeles. CSEC, which is the next point that we made. So that's one of the measurement things that we've done working with commercially sexually exploited youngsters. We've also been a part of our juvenile behavior diversion project, or our juvenile mental health court, and that's the court for young people in the District of Columbia who have all of those mental health issues, right? How do we begin to address it? As I always tell my student, if we're working with a kid who has bipolar disorder, and when he's manic, he goes out and steals cars, and we're only adjudicating him and talking about the fact that he's stealing cars and don't address his bipolar disorder, what are we doing, right? So that's why the juvenile mental health court is important. We also talk about something that I think is rarely discussed outside of college campuses, which is racial identity, right? How do we have a system where all of the kids are African American primarily, or Latino, and we never ask them anything about race? Right? So we've actually started asking kids about race and wondering how their racial identity might impact how they think about themselves, how they think about this system, and we can talk about that. And then lastly, a bit of what you've heard already is epidemiology, right? We want to figure out what's going on with our kids, where are they coming from, what are the risk factors, and how can we intervene? So with that said, I was given the task of kind of setting up the stage and talking a little bit about what's going on with our young people. So hopefully that will be just the start of a wonderful conversation that we're going to be having today. And with that said, I will sit down and be quiet and let the doctor take over.
Good afternoon, everybody. Can you hear me okay? Yeah. Okay, great. So my name is Megan Sullivan. I'm the project director for DCC, which, as you can see on the top of the slide, is an acronym at DBH, and a lot of government agencies be like acronyms, but it stands for DC Social, Emotional, and Early Development Program. Just to be clear, it is not, there's also a school in DC that is also called SEED, so just to be clear, these are separate entities. So I just provided a bit of information. We're really trying to focus on giving you an overview, so really 15 or 20 minutes. I mean, we kind of joked as we were preparing this, we can spend a lot of time talking about our projects, but I really just wanted to give you overview, but of course at any time, our contact information is at the end, so feel free to reach out if you have more specific questions. So today I'm going to talk about early childhood system of care and the overview of DCC, as well as talk about an overview of the evidence-based programs that we're using in this particular project. Our year one accomplishments, next steps as a system of care, and also I think what's really important for you guys is connecting you to resources. And so really giving you the information. You can always reach out to me, but again, we really want to make sure that you have the information that could help you and some of the, either the children and or families that you're working with. So DC Social Emotional Early Development Project is a SAMHSA grant. As you can see, DBH, or the Department of Behavioral Health, was awarded this grant in fiscal year 17. It is a $1 million grant for 4 years. We currently just started our second year. And really, the purpose of this grant was to support the expansion and implementation of early childhood specific evidence-based and promising practices. And so, over the last few weeks, I've been thinking about how am I going to talk about this grant that serves 0 to 6-year-olds with a group of individuals who are potentially working with kids who are already in the juvenile justice system. And so again, I think for some individuals thinking about services for 6-year-olds, wow, that's really young, and mental health, and what does that look like? But I think as we mentioned a little bit ago, our kids and families are experiencing trauma at a very high rate within the city, and so I think one of the important things with this grant is it's providing some services for children at younger ages. And so, again, I just kind of gave my last bullet, but really this grant is focusing on addressing the unmet behavioral needs of young children, birth to 6 years old, who are at risk or have been diagnosed with a serious emotional disturbance in their families. So this is a really busy slide, but I want to let you guys know there's many kind of deliverables and activities that we're working with the grant. Today, we're specifically talking about some of the services and trying to give you the information to connect. But again, this slide shows that there's many different components. As you can see, the first kind of some of the work that was done was really trying to expand our provider network. So this was really looking at how can we expand the services provided across the city. So as you guys know, there was a couple of providers who were providing 0 to 6, but we feel it's really important to make sure that we're hitting all wards of the city. We're providing as much care as we can for this population. So one of the first things that we did as a grant was to expand our provider network. And so now we have 3 providers who have expanded their services to include 0 to 6. So as you can see, Community Connections, First Home Care, and Mary Center, they obviously also provide services for older children and adults, but they've now expanded downward. Mary Center previously was already servicing early childhood. This grant has helped them increase their capacity. The second bullet talks about enhancing some of our existing services. So again, at DBH and within some of our core service agencies, we provide many kind of community-based interventions, what we sometimes use the acronym CBI. So this grant is looking at doing some of that great work, but bringing it down in the age. So again, we've done it with older adolescents and young adults, really looking at some of the services for younger children in the 0 to 6 population. So we'll be looking to expand high fidelity wraparound, as well as working with our family peer specialists and making sure that the certification process includes information and training on early childhood. Because again, the grant isn't just about helping increase services for this age group, it's really about providing training, skills, knowledge to a vast majority of people, mental health providers, but also individuals across the community, anybody touching children in this age group and their families. The third one talks about early childhood training. This program specifically, we will be training our clinicians on 3 evidence-based programs. Our providers have already been trained in child-parent psychotherapy, which I'll talk a little bit more about, but also PCIT, which stands for Parent-Child Interaction Therapy, and then Strengthening Families Coping Resources. Again, really trying to focus on making sure that we are expanding our treatment services, but that we're providing quality services as well. Another very big initiative that's part of this grant is centralizing our intake. And so we often hear about in the community, even when I was a clinician, about how sometimes it's very hard to access services. So people might know that services exist in the community, but they haven't been able to link very easily. And so we will be working with Department of Health and trying to centralize this process so that we can make it as easy as possible, so that when families are ready to engage in services, that we can make sure that it's a very seamless process and they can try and call and get connected as quick as possible. Early childhood mental health consultation, there's also a component of this grant that will be working to ensure that all child development centers, which we often call CDCs within the district, will have access to early childhood mental health consultation. And so this, by 2020, this is really something that we're trying to provide child development centers with some additional support. As you guys know, it's hard work working with children, young children all day, and making sure that they have the resources available if they do have some concerns about a child and or family. And then the last, evaluation. This is very near and dear to my heart. As you guys heard, I have a strong interest in evaluation as well. I think something that we sometimes do well in the district is bring great resources to the district for a short period of time or a limited period of time. Some families and children do benefit from the services, but then once funding is gone, those resources are sometimes taken away. And I think that it is part of my duty as well as our team's duty to make sure that to evaluate the services that we're implementing, determine if they're effective within our population, and if they are, to figure out and come up with a way to sustain these services. It's not fair to bring these services in once we have a funding source, and then if they're effective, to remove them. So again, the evaluation component is very intensive in this project, and we're really trying to see, are the services and activities that we're providing effective, and if they are, how can we sustain them in the future? So that's a very brief kind of synopsis of all of the activities that we've kind of that we've outlined in our grant and are the deliverables that we say that will service our children and families. So I want to talk a little bit about our evidence-based practices within this model. I think that we hear about these all the time, and we know that in research studies, we often find that they are effective. I think what's important for us is that we make sure that these are effective with our children and families that we're working with. And so our evaluation team will be doing part of that. But today I wanted to talk to you about the 3 specific programs. Again, I could talk about each of these for a very long time, but I just wanted to give you a brief kind of snapshot of each of the interventions that are the clinicians that we're training as part of DCC will be implementing. The first one, our clinicians are already trained. They were trained at the end of last August, or this previous August, and it's child-parent psychotherapy. This is a model for young children who have experienced traumatic events. So again, as we mentioned earlier, lots of our kids that we're seeing in school sometimes have externalizing behaviors. They might be aggressive, they might be throwing things. You know, we just see a lot of kind of acting out behaviors. These are the kids that get referred a lot, and sometimes they're just seen as bad. But when we dig a little bit deeper as a mental health clinician, we see that maybe they've had a traumatic experience. And so this intervention could potentially help some of these children and families. And really, the goal is to strengthen the child-caregiver relationship and to help restore a sense of safety and attachment. So we are currently, I should say the providers are currently implementing this. I provided some handouts for you guys. There's a general child-parent psychotherapy handout. Again, this is predominantly, you know, it's an intervention for children who have had a traumatic experience. The second intervention, which we will be training this year in year 2, is parent-child interaction therapy. It's an intervention model for children experiencing emotional and behavioral difficulties. The emphasis is really on improving the quality of the parent-child relationship. And this intervention, some of you might know about it, it gets a lot of kind of media because there's a bug in the air. So the parent is listening while a clinician is either in another room or looking through a 2-way mirror, and they're helping the parent coach while they're providing play therapy in the room. And so it's really the therapist or the mental health clinician is really helping the parent learn to interact in positive ways with their child. This, again, this is part of our year 2 training. It's already being implemented across the city. At some places, Mary Center is already implementing the service. And then the last one is strengthening family coping resources. Again, this is a model for families living in traumatic contexts. It's in a group format. And so families come together over a meal, and it's really around reducing symptoms of trauma-related disorders and increasing coping resources for the family system. So again, all of these things I want to stress that while the child is the one, you know, is our kind of patient or client, all of these interventions are family-focused. There's really no way to provide treatment in these pieces with these kids without the family unit. And when I say family, it doesn't necessarily obviously have to be the biological parents. It can be the caregivers. We have a lot of grandparents participating. Really, it's just the family context. So this is a brief kind of synopsis over the 3 evidence-based programs. Again, as a psychologist at heart, I'm extremely interested in learning and looking at this data of our families who are participating in this. I think it's very important to see if these programs, which are obviously evidence-based, there's tons of research around them, Are they working in our communities? Have we had to adapt them? If so, how are we adapting them? Because again, I think sometimes it's easy to say, well, this should be working. But then when we actually come into the weeds, dealing with children and families who have had, some very traumatic experiences, maybe it's not working in DC, and we need to be able to see that data if it's not. If it is working, that's great too. We want to make sure that we then figure out how to sustain these programs so that once the funding for DCC is gone, that we still have the resources to be able to have these programs. So just a little bit about year one accomplishments. We just entered year two. As I mentioned, our providers were selected. We've trained on our first evidence-based program. And we've also done quite a bit of work around trying to educate around early childhood, just in general. Again, we all kind of often experience children and families 0 to 6. I think we often hear, well, I'm not really sure what a 3-year-old's supposed to do. They change so quickly. And so I think we've really been doing some training around what's normal development, what's not normal development, when should we be concerned, and how do we link people. So we also did 2 early childhood trainings. The first one focused on just early childhood development and the impact of adverse child experiences. If you guys haven't looked at the ACEs research, it's really, really a great research done by Kaiser, and it shows, exactly what the slides were talking about previously, how traumatic events and multiple traumatic events have not only significant mental health concerns, but lead to health outcome problems as well later in life. And then the last training that's up here is DCC trained mental health clinicians for 2 days on a classification system. So it's called DC 0 to 5, Diagnostic Classification of Mental Health and Development Disorders of Infancy and Early Childhood. So basically, kind of how I relate this, it's somewhat similar to the DSM-5, but for younger children. So we often try to use DSM-5 criteria to fit into young children, and it doesn't always match. And so what we are trying to do is really trying to give the skill set and knowledge to mental health clinicians of how does this look different? How does it look the same? And again, this training was very, very intense, looking at what does it look like in a toddler versus someone who might be a little bit older. So again, and I think this is extremely important because again, trauma symptoms might look different in a 3-year-old compared to a 15-year-old and how they're displayed. So again, another busy slide, but I just wanted to kind of show you our next steps. We're training clinicians and beginning to implement 2 additional evidence-based programs. We are creating a childhood community practice and really around a big work group and really incorporating everybody so that we can get voices across disciplines, across different government agencies, against providers, really trying to get as much information as possible so that we can make sure that we're filling the gaps in the right way. I think it's easy to kind of look at big picture and systems and say this is what we need, but I think when it comes down to it, it's really important to get the voice of many different people. And so that's one of the points of doing the work group, and then also convening subcommittees. So there's much, much work to be done, and so I think really trying to get different work groups going so that we can do some of the work in between our larger meetings. Providing additional training opportunities, again, I think speaking to obviously being in the mental health field, I'm a proponent of treatment, but I'm also a huge proponent of prevention and early intervention. It is our duty to also make sure that we're providing enough information so that when there is a concern and maybe somebody is aware of it, that they're able to identify it prior to something more significant happening. So, strengthening our partnerships with other early childhood sectors. So again, Aussie Child Development Centers, DOH with Help Me Grow. Implementing our social marketing plan. So this is another huge component. We know we need to get the word out about resources, but also I think help to reduce the stigma around receiving mental health services, but also letting people know that mental health concerns do start early, and you don't have to wait till a child's a teenager or adolescent to get services. And that prognosis is much better if you intervene early. So again, a social marketing campaign is really important because it does a multiple. Yes, it's important to get our resources out, but it's also important to let people know and to educate them about early childhood mental health. And then last, I spoke about this already, I think developing and sustaining our financial plan. So again, my goal is that at the end of 4 years, the services that our evaluation has shown to be effective, that there is a system within DC that we can help providers or other entities be able to fund these resources that have been effective, even though the SAMHSA funding will be gone. Okay. So these are specific contact numbers for the 3 agencies. Parent Infant Early Childhood Enhancement Program is also known as the PEACE Program. This is actually, they are not technically a DCC provider, however they are a program at DBH that's located at 821 Howard Road that also provides treatment services for 0 to 8-year-olds or 0 to 6-year-olds. They also are trained in PCIT or CPP. And then the last number is the DBH Access Helpline number. If you ever need help just in mental health services, you can always contact that and they can help you. And this last one, I believe, is my contact information. Feel free to email me, call me. I'm always available, even if I don't know the information, I'll try and connect you with somebody who does.
Good afternoon, everyone.
Good afternoon.
I'm going to do my disclaimer up front. Just a couple of disclaimers. One, if I start coughing, I'm going to drink some water. Sometimes it gets hot and it kind of messes with my breathing a little bit, but I'm fine. So that's disclaimer number one. Disclaimer number two, both Dr. Sullivan and Dr. Woodland talked about their busy slides. My slides are a little busy for other reasons, probably because I work with transition age youth. So it's going to do a whole bunch of jumping and dancing and all kinds of trickling down that's, you know, way above my head. But thanks to my wonderful colleagues who helped me put in all those dancing figures, that's going to happen. So I'm just letting you guys know. And my last disclaimer, which was said in my bio, usually when I speak in front of people, they go, "Where are you from?" Yes, I am from New York. So just kind of putting it out there. As was said earlier, I am the project director for what is known as Our Time. And Our Time is a grant that was awarded to the Department of Behavioral Health 4 years ago. We are in our 4th year, 4 years ago, to create a system of care for transition age youth, those individuals 16 to 25. What was happening, see, I told you. What was happening was that a lot of times our young adults, those individuals kind of now beginning to assert their independence, those individuals turning 21 kind of fell out of the system. What we noticed happen is that individuals with mental health illness round about the age of 16 to 25 tend to fall out of the system and then come back into the system later on, needing more acute services. So the purpose of this grant was to really try to create something that ensured that our young adults not only transitioned into adulthood accurately and successfully, but also that they had an opportunity when needed to access services, and there were services available for them. Much like this slide, just today, I did an interview with a young man who was trying to get into Wayne Place, and much like this slide says, he was kind of feeling isolated, kind of feeling like he was coming out of the child welfare system and really didn't have any place to go. Really was trying to take a different path in life and not really hang out with the friends that he had previously hung out with. Trying to do something different, trying to get on the right track. And so, kind of much like this slide, feeling very isolated and alone. Just to take you back a little bit, if you guys remember, there was the shooting up in Connecticut, the shooting where we lost several little ones. And that individual had mental health illness. Under the Affordable Care Act, President Obama extended access to mental health. So it was part of that whole thing that he kind of brought together and convened several different groups, not just in Connecticut, not just in DC, but all across the nation, trying to address the mental health concerns. Here in the district, back in June 2013, Mayor Vincent Gray brought together a group of people to kind of talk about and discuss the mental health concerns in the district. From that, from several meetings, several big meetings, little meetings, meetings that included young adults, meetings that included community representatives, our time came into fruition. As I said before, our time focuses on getting our young adults from childhood into adulthood successfully, making that successful transition. We understand that there are many emotional and behavioral disorders that present themselves during adolescence. And during that time, when individuals have those mental and emotional disorders, they tend to kind of pull away and don't necessarily transition very well. They drop out of school, they don't train in anything, so there's no vocational training. They don't seek any kind of help because a lot of times our young adults go with the concept, I can do it, I know all the answers, this too kind of will pass, I know what I'm doing, which is not always the case. Often skill development can be hindered by those serious emotional disturbances, and what our time hopes to do is kind of help our young adults work through that. And I'm going to put up the slides, but of course I'm not going to read through all of the information on the slides because I'm sure these slides are going to be sent out to you guys. Kids with severe mental illness or serious emotional disturbances often face discrimination, and I think that's what Shanika was talking about. That a lot of times in school that nobody really asked what was really going on. It was more or less you're doing well in school and that was good enough, right? When they get into situations such as that, what tends to happen is, again, much like Shanika had shared, is that our young adults tend to recoil, withdraw, maybe not even finish school, and end up doing things that do not put them on a trajectory to successful adulthood. A lot of times they're unemployed, they have residential instability, and lower educational opportunities. This is much of what I've been talking about, the statistics that those individuals who suffer with mental health in the 16 to 25-year age range who do not get help or supports, they're 3 times more likely to live in poverty. Kids with mental health have a higher rate of substance abuse than any other age group. They are 3 times more likely to engage in criminal activity and subsequent involvement with the juvenile justice system. Over 60% are unable to complete high school, further impeding their educational and employment opportunities. And of course, the lack of stable housing. And in the district, we know housing is at such a premium that if you don't have the right resources, then it is very unlikely that you'll get housing in the district. So back to that young person that we saw in the beginning, feeling anxious, isolated, overwhelmed. What do they do? Our time was formed in an effort to kind of work through that. What we try to do at our time is not really label anyone, not really diagnose anyone, but really engage our young adults in services just in a more, I guess I would say unconventional and kind of relaxed way. It's important for our young adults to kind of know that they're not alone. And so a lot of what we do is, again, Shanika talked about the youth council. So we let them know, our young adults, we let them know that they're, we let them know that their voice is being heard. We ask them to give input on those things that affect them in the district, policies, plans, programs, that kind of thing. And that's really what the youth council is all about. Our time looks to connect our young adults and our youth with services that are specifically geared to them. We try to make sure they're connected with supports. And what we have available to them is transition specialists. And our transition specialists are TIP trained, and TIP stands for Transition to Independent Process. And so these individuals connect and work with our young people for up to 6 months, ensuring that they get the kind of services that they need. So again, we talked about them dropping out of services. We talked about them not being able to access services, not necessarily knowing how to navigate the system. The transition specialist is there to do that. Under the Our Time program, we offer evidence-based practices to support the work that we're doing. So the first one I talked about is Transition to Independence Process, which is TIP. And TIP is a way of engaging young people. It's a way of empowering them to find their own destiny. We also have Transition to Independent Process and Assertive Community Treatment. And that's the TIP program along with the ACT program combined for those individuals who have, what's the word I'm looking for? Reoccurring or severe mental illness. The other program that we have, which is an evidence-based program, is Adolescent Community Reinforcement Approach, also known as ACRA, and that works with individuals who are substance use individuals. So it works with the individual as well as the family to kind of help work through those substances. And then supported employment and supportive housing. Just telling you a little bit about the supported employment and supportive housing. Wayne Place is a transition living program. Wayne Place is located in Ward 8 and offers housing to 44 young adults in apartment-style living. Each young adult shares an apartment, and it really is about independence. It really is about helping an individual in a safe atmosphere begin to feel what it's like to live on their own. They stay at Wayne Place for 18 months, and during that time they are encouraged to either work, go to school, or both. Start looking at options for housing, long-term housing, because again, it's only an 18-month program, and really explore those kinds of things that they would need to be successful. For our young people at Wayne Place, they get dual supports because a lot of them are connected to the transition specialist from one of our provider agencies. Plus, they also have a case manager on site that also supports them with linking them to services and to their needs. A supported employment program is offered to any of our transitional age youth that come through the Our Time program. Supported employment, a little bit different from the regular supported employment, only in that we try to make sure that rather than giving our young people an opportunity to find a job, we try to set them on a path where they find a career. So we really looked, and whether it's going to be their first career or their second career, we really tried to kind of dig deep and figure out, do you want to be in the health field? Do you want to be in the culinary field? What kind of field do you want to be? And then find them services, jobs, supports, those kinds of things that put them on a path for long-term career opportunities. In addition to that, under Our Time, we try to make sure that we connect our young people with educational services. As I said before, a lot of our individuals who experience mental health, whether it's something they acknowledge or not, tend to kind of withdraw and don't pursue their education. A lot of times, young adults come back in and maybe they've only finished 9th grade and they're like, I don't want to go back into school. What do I do? But I really do want a high school diploma. We work with OSSI and some of the other agencies to make sure that those individuals are, again, connected with services and put on the right path to get, whether it is a high school diploma, and for some of our young people, a college degree. Okay, I already talked about that. Okay. Our main goal is to make sure that our young adults are happy, healthy, self-assured, and independent. And that they are actually receiving those services that are geared to them. We try to offer early interventions and early screenings to ensure, again, as Dr. Woodland said, that when one is going up and one is going down, that we are capturing them as early as possible and connecting them with what they need. Again, we focus on those individuals 16 to 25 years of age who are at risk for serious mental health or substance use conditions, experiencing challenges with co-occurring disorders, interruptions with educational trajectory, residential instability, or disrupted provisions in services due to insufficient identification. And just to tell you a little bit, what's a little bit different from this program, the Our Time program rather than going through the regular system. Our time, if you see at risk, that's the one thing that is a little bit different. In order to get a lot of the services in the district, individuals need to have a diagnosis, an Axis 1 diagnosis. Right now, again, because our young people are so reluctant to kind of admit their need for help or their need for services, we do not require those individuals to have an Axis 1 diagnosis. What we do try to do, again, is link them with the transition specialist who will make referrals for assessments that may later come out that they do have an Axis 1 diagnosis. But the ultimate goal is to connect them to services first and foremost, get them into at least asking for help, at least showing them where help is available before kind of shutting things down by saying, you have this going on or you have that going on. Right now, our services are provided by 2 CSAs, MBI services, and Community Connections. Now, I'm going to make the disclaimer that they're not the only 2 that provide services for transitional age youth, but they are part of the Our Time program. So they've been trained in specific services for transition age youth. So they're all trained in TIP. They either offer TAC, which is the TIP and ACT together, or they offer supported employment specifically geared to transition age youth.
Wait, go back.
Somebody said go back? Oh. Okay. Just a few things on the numbers. 3,200 community members have been educated on TAY-focused services and supports during outreach. We do a lot of outreach meetings trying to get the word out that we have these services available. The youth voice, because of my mental health illness, no one took me seriously until I became connected with the Our Time program. So a lot of what we do in the Youth Council is really respect our young adults as subject matter experts. They have lived it, they understand it, they know it, and we really do take them seriously. 150 young adults who never received mental health services were connected with TAY-focused services and supports. And those are services and supports that are specifically geared to support individuals 15 to 25. I would be still hustling on the street had it not been for these programs. My transition specialist is the coach that I want when all bases are tied and you're at the bottom of the ninth. 119 youth and young adults have lived and received support from the Wayne Place Transitional Housing Program. I'm really learning how to budget my money and budget my time and live on my own. Next week we're having a graduate from the Wayne Place program who's coming back to speak to the residents and also pass out toiletries that she's collected along the way. So it really does kind of help put people on a different path. 22 TAYs have been enrolled in supported employment. 125 young adults participated in enrichment activities. And just to talk a little bit more about our enrichment activities, we've done things like boating, sailboat racing, race car driving. We've been to plays, Alvin Ailey, Dream Girls, just a number and a variety of things that we try to take our young people to show them that there are other outlets besides maybe just hanging out on the street corner, maybe, as they say, and I'm probably going to say it wrong, maybe doing the turn up. I think that's how you say it. My kids always say it. It's not the turn up, it's the turn it up. Well, whatever, you know what I'm talking about. There are other opportunities for outlets other than just kind of hanging out. A lot of our youth are really in, I think this past summer we went fishing, and we may have some pictures further down of some of the activities we did. We went fishing and the kids are still talking about it. We ended up catching over 13 fish and everybody got to take their fish home. So it's just really giving them a different experience that they might have not had. One, showing them another way to kind of release tension, and also kind of bringing them together with a group similar to them that are experiencing similar things. Again, in all those enrichment activities, we really do try to make sure that we pass out information on those resources that are available to them. We usually, whether it's on the bus, whether it's at the site, we usually have a presentation about TASE services, Transitional Age Youth Services. So again, we try to do a no pressure thing, but just to let our young adults know that there is something for you. And there are others like you who are accessing this service. 26 young adults have been served by first episode psychosis, and I didn't really talk about that. That's for those young adults who have had their first break, their first psychotic break. That's offered through Community Connections, and we try to get in the very early stages. They work with a resilience specialist, they work with a psychiatrist, they work to get their meds managed correctly, and really work to kind of get back on track. What we don't want is that first break to be the only break that takes them down a road they cannot return from. 124 TASE are connected through our time through social media. We do a lot of advertising on Facebook, Instagram, Twitter. You guys can access us at the end of this presentation. We'll have all the different, dare I say, handles. Date myself, but we'll have all the different sign-ins for you to access. And 30 youth and young adults regularly participate in our Wednesday night youth council. And I can't talk about the youth council enough. Several individuals have stepped up and come to the youth council to get information for RFPs, to get youth voice. We are open to that. We are willing to share our resources. Shanika, as well as 4 of our other young adults who were originally members of the Youth Council, are now working with one of my colleagues, Kristen Adams, to take over that Youth Council and lead it. So they've kind of graduated and stepped into new roles. They do recruitment and all those kinds of things. In addition to that, which is not up here, and this is something new, both Megan and Dr. Woodland talked about trauma. And right now, what we are doing is we are training a group of 5 young adults in trauma-informed care. And those young adults are going to be the ones that kind of go around the city and really talk about what does trauma look like from a youth perspective. How does it manifest itself? How does it show? What are some of the behaviors? So once we kind of roll that out, please, please, please don't hesitate to contact me to have them come out to speak to your group, whether it's adults, whether it's young people. We are looking to get them exposure to kind of train and help people understand trauma in young adults. Since the inception of the Our Time grant, we've learned from our young people that they need new approaches to get engaging into services. And again, that's why we don't do the diagnosis. That's why we do things like the enrichment activities. That's why we allow individuals to come through any of the different doors, whether it's through Wayne Place, whether it's through the Youth Council, whether it's through any of our partner agencies, any door you could kind of come through and get connected with Our Time. They also need more of a presence when it comes to knowing about youth and young adult related services. Again, we've tried to meet our young people where they are in terms of going on social media and letting them know that these services do exist. These services, not only do they exist, but they are geared to and for individuals 16 to 25 years old. Youth and young adults also want to feel like a partner when dealing with their health, lives, and ideas put on the table. And we definitely are making it a point of doing that, not only, as I said, in the Youth Council, but it's part of the approach that our transition specialists use when working with our young adults to link them to services. It is not about you're going to do this or you're going to do this now. It's about what do you think you want to do. Just today, again, in the interview with the young man who talked about, well, what are my expectations? Should I be expected to Wayne Place? And, you know, he was kind of told, your expectations are that you find your footing, you do things constructively, and you move in a direction that's going to help you be self-sufficient. That doesn't mean kind of laying around. For most people, you can't be self-sufficient without a job or without education. So we are looking to support you in that. Young adults have a huge need for a support system and are capable of identifying those in their corner. So we really do try to listen to what our young adults are saying. If they say they don't want mom to be involved, we're not pushing to have mom involved. If they say the neighbor next door is more of a support to me, then that's the person that we are going to acknowledge as a support to them. Young adults want to stay together as a family when having a baby, but the current housing state in the district does not provide many options to keep young people together. I would love to be able to say that we have housing options for young adults who are parents, but we don't. It is something that we are talking about, thinking about, and maybe in the future we will have. What we do plan to have, though, is, again, under Our Time, our whole goal is to train a cadre of young people to disseminate information. Information comes better from those who have utilized it or in it or in the same age group. So we will be looking to train up a group of young adult trainers in the Black parenting experience model, and they'll be our expert trainers to deliver that training to other young adults around the city. As Megan talked about, we don't want our services to kind of go away. So we are looking in this year, our fourth year, financial plans and how to sustain services ongoing. Of course, the big hurdle to get over is how do we get past, as I said, that DSM diagnosis in the first place, but we are working on that and hope that by the end of this year we'll be further along and have an answer to address that. Of course, we need to work with other stakeholders, and so we've tried a couple of times to engage, our partner agencies to kind of hear their input and hear their goals. And the best I can say is that we haven't had the stellar turnout that we would like. But I do ask that for all those who work with this population, the 16 to 25-year-olds, should you get an email from me asking you to come to a meeting, we can't do it alone. And when I say we, DBH can't do it alone. A lot of times we are servicing the same young adults, sometimes providing the same services, and if we do it together, there is a bigger pool of options that we could afford our young people if we do it together. So I do ask that as emails go out, if you can't go, please pass it on to somebody who can. The DBH team consists of myself, Leslie and Byam, Kristen Adams, who's in the back. Kristen, raise your hand. And Angela McCrae, also in the back, Angie. And you could contact any of us to get services or to be connected to services. In addition to that, our partners, our provider team partners are Community Connections, MBI Health Services, Total Family Care Coalition, they are a community partner, and Wayne Place is our housing partner. The only piece of information that's incorrect is Vera Johnson is no longer part of Wayne Place, but should you have any questions about Wayne Place, please don't hesitate to give me a call. But through any one of these providers, you can get connected with the Our Time services, and of course through any of my colleagues. Again, our social media connections, and it would be great if you guys could connect on. Enrichment activities are open to any district resident, 16 to 25, so when we restart those, it doesn't matter if they're part of DBH or not. We really are just trying to get the word out and let our young people know that there are services that are available to them. Again, my contact information.
With the permission of the panelists, I will be sending the slides out, so you don't have to rip your phones, etc. Try to send out contact information. I'll definitely send stuff to you.
Thank you all.
Good afternoon. Good afternoon. My name is Brittany Dash, and I'm a family functional therapist, and I work for the Department of Human Services. My slides aren't busy, so very quick, simple, to the point. I'll probably do a lot more talking than it is on my slides. Okay. So what is FFT, which is basically the acronym for Functional Family Therapy? It is a short-term, culturally sensitive, strengths-based treatment strategy. We focus on motivating at-risk youth and strengthening families, and we address behavioral and emotional issues in the adolescent population. So short-term, we are usually between 2 to 6 months. 2 months for families who may have very little issues. Maybe they need a little tweaking here and there, maybe not a lot. 6 months for families who are a little bit more intensive. Just because we say 6 months doesn't mean if 6 months come, we automatically cut you off. It's just more so that's more of the short-term range. If we're in 6 months and the family is still at a point where they still need more assistance, then we will continue working with the family to make sure that we transition them out in a positive way. Yeah, we're focusing on motivating at-risk youth and strengthening families because a lot of our families that come to our program are broken. They have very little faith in the system. And so coming into our program, we're focusing on pushing them and motivating them to believe that the program actually will work for them. And definitely addressing the behavioral and emotional issues in adolescent population. A lot of them come to us with mental health issues or mental health issues that have never been addressed. They've been through multiple programs, so they have multiple diagnoses. Either they're overdiagnosed or they're underdiagnosed. And so coming to our program, we do a lot of trying to evaluate what is going on with the family that we will be able to assist them to get them in a more stable position. So who do we serve? We serve adjudicated minors for probation, youth at risk to placement for probation, status offenders, and our status offenders are usually youth that would be charged by something that an adult wouldn't be charged for. So you have our youth that are who may have a charge for smoking or alcohol or truancy, running away from home, or anything that's basically beyond a parent's control. So those will be your status offenders. Youth served by mental health or child welfare agencies. So we get a lot of cases from different mental health agencies who feel like their family, a child's family would benefit from family therapy, or child welfare where we have CPS reports, a case that may be a family that may be going for reunification, or a family who may be at risk for separation. So working with the family so the child won't be pulled out the home, or working with the family so the child can stay in the home. So either way, that's how we get those. And our age group is from ages 10 to 17. Because functional family therapy is short term, it makes it a lot harder to work with anybody under that age. We don't do a lot of play therapy, so anybody under the age of 10, it may be a little harder for them to benefit from it. That doesn't say that if I work with a family that I wouldn't get a family who has siblings, a child who has siblings who may be 5 or 7. And if I'm working with a family plan, they're going to also be included into it. The targeted for at-risk youth. So these are things that we kind of come into contact with. The level of conflict in the home. You know, the physical, verbal altercations. Those are really big. We have a lot of clients that are physically fighting with their parents. Verbal altercations. The police are called a lot. So it's a lot of chaos in the home. So these are the same kids that we're asking to function on a normal daily basis in school, which is very hard for them to do. We have family separation and reunification. So kids who've been pulled from their families or being put back in a family who they have very little knowledge of, it's hard for them as well. So that's definitely an area that we work on. Youth incarceration, kids who've constantly been in and out of the system, been in and out of jail, group homes, different things of that nature. So working with them is very crucial to helping their family also adjust to how to get used to them being back in the home. Again, I talked about the ages, and I talked about their mental, emotional, behavioral risk. You know, what are their diagnoses? What's their emotional stability like? And what are the behavioral risks? How does the household impact all of that? And not only in the children, but the family, but the parents as well. If you have a mother who has mental health issues and the mother is calling the cops all the time and saying the child has done A, B, and C, well, you now have a child who's in the system dealing with the cops, but we haven't yet to address that the issues may not even be with the child, but with the mother. So coming into the homes, we're addressing all of that. What is actually going on? What is the bottom line? What's the underlying issue of the family? You know, limited protective factors. You know, what's the parenting like? What's the social emotional like? What is the social connections in the community like? What are their protective factors that's going to help them, as well as the support systems? Who do they have in their life? What does their family support look like? What does the school system look like? Do they have all around wraparound services? All of that plays a part into how we work with the family. So FFT, being at a short term, we have 3 phases. Our first phase is the engagement phase. And the engagement phase is a lot like we talked about earlier, as in a lot of our clients don't trust people. They have people that come in and out their homes. You have people who have threatened to take their kids. You have people who have threatened to put them in jail. You have all kind of, they've been a part of so many different programs that one of the main things that we hear when we go into the home is, we've already tried this already, nothing doesn't work, he just want to do what he want to do. So so coming in, engagement and motivation is our main goal. Working with the families to establish what they want and what they're looking for in family therapy is important. If I'm going to engage with a family, I'm trying to get an idea of how can I make your family function the way that you want them to function, that's going to be better for them. How I function in my household is going to be completely different from the way someone else functions in their household. So I can't come in and tell a family who likes to yell that yelling is inappropriate if it works for them. So my job is to meet them where they are and help them function the best way that they can function, so that overall the client, which would be the youth, is functioning good in all environments. So in engagement and motivation, we do activities, we play games, and that's the time that I really get to know the family. I get to learn their family dynamics, I learn their weaknesses, I learn their strengths, and during that time, we basically assess the family for the areas that we feel like they need to work on, as well as we ask them the areas that they feel like they want to work on. So it comes from both sides, what we see versus what the family sees, and we put it together. And once we get a good rapport with the family and we reduce the negativity, we build hope with the family, and we build an alliance with the family, which is very important, because in building an alliance with the family, it allows me to say the things that I need to say. The things that will probably hurt somebody's feelings when they don't know you that well is the things that I'm able to say once I build a good alliance with the family. So I can tell the mom, you're wrong for how you handle A, B, and C. Or I can tell the child, the way that you did this won't get you to that place, without them saying, who are you? You don't know me like that. So the importance of engagement and motivation is for them to trust me enough that they take my opinion and move forward with it. So once I have all that information collected, we go to behavior change. And in behavior change, we do interventions. Our interventions are based off of whatever's going on. So if I have a family and communication is an issue, we work on communication. If it's anger management, we're going to work on anger management. If it's trauma, we're going to work on trauma. Grief and loss, we work on grief and loss. We have a variety. Our families come with a variety of issues. We have a large Hispanic population, so we have currently on our staff, we have 2 bilingual therapists. So that works really well for the Hispanic population because there's very limited services for them. And so a lot of families that are bilingual, some of their families haven't had their kids for a long time, so getting them back adjusted to their kids from coming from a whole nother country to live with them has been huge. So just developing plans around adjusting families to making better decisions for themselves. And during this time, I've also looked at what was going on with the family that I can also assist them. So if during the engagement phase I found that that the child or the family would benefit from other resources, we're going to also make referrals for them too within our agency. So during that time, a kid may benefit from mentoring, from tutoring, from a mental health assessment. If I notice that maybe something else is going on, we have life coaching for parents. So if I feel like one of the parents would benefit from a life coach, that would also be something that we will make a referral for in addition to them doing family therapy. Group therapy, anger management group therapy is also something that we'll put them in too. And if it's a substance abuse issue, we'll refer them to a program. So in behavior change, those are when we're putting in all those interventions to make sure that we're balancing out what their needs are overall and working on plans within the family. We meet once a week for between 45 minutes to an hour, and we'll meet more if the family is in a more intensive need kind of position. And the last phase is your generalization phase. And that's our phase where we're preparing for termination. Once we get to generalization, we're looking at how well the family is able to do things without us. In behavior change, we've already worked on all the skills that they needed. So at this point, I should be coming into therapy sessions where you could say, yeah, we got in an argument the other day, but my mom took her break, she walked away, and then we came back and we talked about it. And then we were able to settle A, B, and C. At this point, I'm coming in to talk about, well, how did it feel for you to be able to process that and move on. So once the family is able to move forward, then we know that the family is ready for termination. And the goal for the family at that point is to understand that relapse happens, issues happen. A family doesn't go without problems or any type of conflict. The goal is to teach you how to use the necessary coping skills to handle things when they do occur. So in general, we talk about stability, we talk about relapse. We develop a relapse plan for the family for how do we handle this when such and such does this again, because it may happen. And so once the family gets to a place where we feel like they're doing well, we close out the case and we move forward, making sure that any other referrals that they possibly may want to participate in, we put them in. Challenges of FFT. Staff selection is a huge challenge because one of the things about FFT is you have to be a relentless therapist. We get a lot of, which goes into one of the challenges is client participation when services are recommended but not mandated. A lot of our clients that are recommended to the program but not are mandated don't necessarily want you to come into their home. They don't necessarily want to participate. So somebody's recommended them, and a lot of times you go to a home and they're not home, or you make an appointment and they say, oh, I can't meet you this day, or I can't meet you that day. And so a lot of it is resistance because they don't feel like what you're going to offer them is going to work. So a lot of times, the referral may have been a month before, and I may have chased you down for 2 months before we actually have our first session. That can be very stressful and frustrating to individuals who just want to give therapy. And so to have to chase people, to have to go to a school and meet with a client or meet with a kid and say, hey, I just need you to show up. Give me one chance. Just meet with me for 30 minutes and we'll see how that goes. To have to meet a parent at their job and say, hey, can you show up? Let me try this or that, or call them continuously is a lot. So being able to select a staff that has the mentality as well as to work with the population that we work with is difficult because home-based therapy is a whole different ballgame than somebody coming in your office. You know, you're going into their household, you're sitting on their furniture. If I go into somebody's house and they don't have any furniture, I'm sitting on the floor. So they have to feel like I'm just as comfortable in their home as their cousin or whoever comes in, because that makes them feel okay about it. If I see a rat run across the carpet, I gotta act like I don't see it, even if I'm scared. So it doesn't matter. It's just being able to handle going out into the community, whether the neighborhood is the best neighborhood or a neighborhood that has high crime. We're walking in and we're going in, and we may adjust how we dress. We may adjust a lot of things, but being able to handle that is not necessarily everybody's cup of tea, which goes into staff turnover. At our agency, we don't have a lot of staff turnover because I guess they did a good job of staff selection as far as for the FFT program. But staff turnover can happen because it is easy to burn out if you don't take care of yourself. So being able to take care of yourself as a therapist is very important because it helps us be able to function with the families when they are rough or when they are tough, when I'm supposed to have an hour session and it turns into 3 hours because they won't stop talking. So, you know, that's a lot for when you have to do it all day, every day. And families who are in crisis, whose crisis need to be de-escalated before FFT. That's probably one of the biggest challenges we have. A lot of our families, a lot of referrals are referred prior to a family being de-escalated or prior to a family not being in crisis. If a mom has maybe schizophrenia or she's bipolar and she's not being treated, it's probably not the best referral for an FFT case because she's in high crisis, which means nothing that I'm probably going to provide to her right then and there is going to benefit the family because she needs other treatment. So being able to make a referral to to the appropriate service is important when you're dealing with your clients. Everybody or every family could benefit from FFT, or from family therapy in general, but knowing the timing of when to refer them is very important. Because if I come in and you're on crisis, I can't really do the model. I can't engage with you and motivate you because at this point, you're in crisis. I have to give you a plan off break. And if I'm giving you a plan, I've learned nothing about your family. So I'm basing the plan off of 5 minutes of knowing you, which is very hard. So it's important to, when you're making referrals, to make sure that the clients are ready for therapy. And ready for therapy doesn't mean that they don't want it, but ready for therapy as in mentally available. So, our expected outcomes of functional family therapy is just for them to be just to improve to reduce emotional instability, reduce substance abuse, delinquent behaviors, violence, and just to improve the overall function of the family. If we're able to improve the overall function of the family, then we've done our job. FFT is not it does not cure every issue with the problem. We basically provide them with the necessary skills that they need for their family to function. And for most of our families, the success rate is very high. And we do what's called booster sessions. So what happens is even after I close your case, we still are able to do a booster session with the family. So if I close the case 6 months ago and the mom calls me and say, hey, such and such has been doing A, B, and C, can you come out? I'll say sure. And I'll go back, I'll do a booster session. I may do 1 or 2 sessions with the family and exit right back out. Sometimes they just need a little push, sometimes they need a reminder, sometimes families never call again. So the great part about FFT is that you still have the ability to utilize us even afterwards. And we have, a part of our program, we also do other activities. We take the kids on college tours. They usually go on a college tour in the fall, and they go on a college tour during the summer. They go to a lot of the HBCUs all the way down. I think this summer they went all the way down to FAMU. They went to Morehouse, Spelman. They went all the way down to all of those schools. We took them on ski trips. Over the summer, we went on a camping trip where we spent 5 days in the woods. That was quite an experience that I don't plan to probably do again. But the kids actually, those were kids who've never been camping before. We had no phone service, they couldn't use their cell phones, so it was a great experience for them. And the idea is, like some of our panelists have said earlier, is to give them experiences that they don't normally experience. Some of our clients have never left out of the DC area. And so to give them those types of experiences are very important, and it allows them to look outside of the box. And so just providing them with more options is what we also look at too. So in addition to just providing them with family therapy, we also want to motivate them for their life in general. So, and also, if the client may get referred for family therapy, but family therapy is for the entire family. It can be for as many people as they want in the session. I've come to a household where it was supposed to be 2 people, and 10 people was there when I arrived. And so I had to prepare myself to do a session with 10 people, because those were all people who were an intricate part of the child's life, and that's who the family wanted to participate. So we adjust and we make different moves in order to make sure that the child overall stability is going to be improved. So that's the basis of family therapy. Thank you.
All right. Can we give all of our panelists another hand, please? Thank you. So as you see, it was really a wealth of information, and we got to hear really about childhood throughout the developmental space, from 0 to 6, on through transition age, on through family. So, we were really able to talk about young people across the continuum, which I think was excellent. I imagine we're going to take the opportunity to have the audience ask a couple of questions, but I'm going to take liberty given that I'm moderating, and ask the first couple of questions. And then I'll look to the audience. So if you guys have questions, please start getting them ready, as I'm sure you will. My first question just really has to do with accessibility, right? Often in the District of Columbia, we hear that so many of these services are overwhelmed, and it's difficult to get kids in. So I wanted to hear from each of you all, and just tell us about accessing your service, and if it is indeed an easy process, or if there's a waiting list, or what does that process look like? Dr. Sullivan, can you start?
You can't hear me, can you? Oh. So access has been an issue. It's one of the reasons. Can you guys hear me? Okay. So access has been an issue, I think, for 0 to 6 population, which is one of the reasons why DBH and the team applied for the SAMHSA grant. One of the major components of this grant was to expand provider availability capacity. I think I mentioned that Mary Center actually already provided services for this age group. However, they do have a waiting list for their PCIT services. And so while most of their staff is bilingual and can provide these services in English or Spanish, there has been a waiting list. So it was one of the reasons why DBH felt it was important to apply for this grant so that we could expand services. I will say, kind of on the opposite end, now that our clinicians are trained up in child-parent psychotherapy, the referrals have been a little bit slow, and I think that's partly because people don't know the services exist. Also, I think it's a little bit around, it's a specific intervention for children and families who have experienced a traumatic experience. So again, you're looking at a smaller population. But I think there has been a need. I think also I did mention too previously, I think some of our families and children have tried to engage in services and honestly haven't had the best experience. And so they have opted to not kind of seek those services again. And so we're trying to kind of all those different access points, trying to increase provider capacity, but also really get the information out in social market, but also making sure that once families are ready to engage, that they have a positive experience so that they can stay connected in services.
Thank you.
For the 16 to 25-year-olds, what I would say is that there are services available. What you asked about was access, but access to our time, you could enter through any of the provider partner stores, Community Connections, or MBI services. Or you can enter simply by calling DBH. My number, there is no big referral process, nothing needs to be filled out. It usually just is a phone call to any of us listed on the slides. The only one that demands a little bit more of a referral process would be Wayne Place. And of course, that is because it is an independent living program. And we have to make sure that our young people are prepared and ready to live independently. A lot of times individuals think that they're moving into a group home kind of setting where somebody's going to kind of hold their hand and wake them up to take meds and wake them up to go to a job or wake them up to go to school. It's not at all like that. It really is a dose of being an adult. And so for that one, there is an application process and an interview process that a young adult must go through.
Is Wayne Place full now?
It is not full. There is availability in Wayne Place. However, there is a freeze on taking in individuals only because we are in a transition period. However, I believe within the next month or so, that should open up. So now is the time. There is not a wait list at this point, but now is the time for individuals to submit an application. I will send an application over to Diamond so that she could send it out to everybody here. And on the application, it gives the criteria for individuals to enter into Wayne Place. Individuals are placed on a wait list on a first-come, first-served basis. You must be a homeless youth in order to enter into Wayne Place. So it can't be because I don't like mom's rules, I want to kind of move out, I don't like uncle's rules, I want to move out. You really and truly should be a homeless individual in order to move into Wayne Place.
I have a quick question about Wayne Place. Do they need to have an underlying diagnosis in addition to being homeless?
Mental health diagnosis or aging out of foster care.
Thank you.
Before we start with the questions, we'll come back and I'll make sure you're the first one. All right? Thank you. Go ahead.
So in reference to access, we're located at 64 New York Avenue Northeast, and basically we do self-referrals as well. So the referrals that we get from the schools or child welfare or the court is not the only referrals that we get. Is there a waiting list? Yes. But our waiting list usually go through really fast because we have we just hired some more therapists, so we have a pretty large group. And so as soon as we're closing cases, we're getting new cases as soon as we close. So for example, at the end of the month, I'm closing 4 cases, which means 4 more cases are going to come right directly to me. So it's very easy to access us. The process is just you call or you come up to the agency, they do an intake with you, and then they set you up with the therapist. As soon as we receive your file, we call you within 24 to 48 hours, and we set up a time to meet with you. So the turnaround process is really fast. As soon as we get your file, we should be meeting with you within the next 7 days.
So what I'm going to do, because I see there are a lot of questions coming out here.
It's not a question.
Okay.
It's an enhancement to Ms. Leslie's answer.
All right. Go ahead with the enhancement.
She mentioned in her slides one of the services that serves youth and transitional age populations, ACRA, which is the Adolescent Community Reinforcement Approach, serving youth with co-occurring disorders, mental health and substance use related disorders. Access is really easy to that specific service, and you don't need to be a youth who's associated with Wayne Place to access that service. We need referrals. We don't have an exponential amount of money for that service type, but we do have grants and local dollars associated with paying for that service. So at this point, if folks need that service, we want them to get it, and we encourage referrals. So ACRA is the Adolescent Community Reinforcement Approach. It is a harm reduction model or abstinence-only model for youth ages 12 to 24. It also includes the TAY population of 21 to 24. They are seen exclusively at Hillcrest Children and Family Services and Community Connections. The great thing about access to that specific service type, which is an evidence-based practice, is that it's self-referral or referrals from the community, referrals from teachers, and they don't have to come through DBH. They go directly to one of the agencies if it's something that they're interested in.
Thank
That's
you.
my plug.
Thank you. So what I'm going to do, I have a few more questions, but I'm only going to ask one more right now, and this is one that CJCC staff wanted me to ask, and then I'm going to turn to you all, because it sounds like you have a number of questions, and I want to make sure we get to those. So my question is, in an ideal setup, with no budget constraints, what should mental health care look like for youth in the District of Columbia? Sounds like it's a good question. All right. No budget constraints. So I guess we can start this way and come back down now.
Okay, so ideally, I feel like it should look like all of the clients that we have coming in are getting extensive mental health evaluation. A lot of our clients have never been evaluated, or they've been evaluated by different agencies that hasn't been really in depth. And so knowing what their diagnosis is very hard, or even if they are overdiagnosed or underdiagnosed, has been a challenge for us. Being able to connect them to multiple services or to assist them with certain poverty issues might also help us in pushing forward with some of the mental health issues that the family is dealing with. I'm gonna let them add on to it.
I will say this to you though, if you're dealing with kids who you know were justice involved, juvenile justice involved, and you're looking for those evaluations, please feel free to call the Child Guidance Clinic. We may be able to help you with that.
Okay, I will
So,
be sure to do
that's not even utopian. We can handle that right now. All right. Ms. Vine?
I would have to agree with the evaluation piece of it. However, I would like to see that happen a little bit further down the road. Again, as I said in my presentation, for our young adults, 16 to 25 years old, who are not always ready to admit having a mental health issue, it kind of pushes them away if they're diagnosed with something too early. So in a perfect world, it would be to provide services and supports on an as-needed basis without all the constraints of an individual needs, access one diagnosis in order for this to be paid for. Of course, for those providing the services, not having to necessarily meet productivity issues, because that always presents a problem. But just kind of being able to meet our young adults where they are, walk the walk with them, and then help to guide them on a path that helps support them in the long term. And if you give me the money, I'll build it.
I think for me, a couple things come to mind. I think that, especially working with the early childhood population, while treatment is important, I think early intervention and screening, I was happy to hear that you were saying that everybody coming in is having a mental health screen. I think for me, it's really providing all individuals who might be touching young children with the knowledge and skills to be able to identify what's normal, what's not abnormal, what's abnormal, and being able to have the skill to maybe have that difficult conversation with a parent, not labeling them, but again, just identifying that earlier on so that services can be put in place. I think too, another kind of thought that comes to mind, in an ideal world, I would really like to see the stigma around mental health be decreased, and so that I know that Marie Morales-Black is here, and I don't remember exactly where we were, but I remember her specifically saying treating mental health the same way health issues are and health conditions are treated. And I think really when we get to that point, I think when people are able to go to a doctor because of a mental health concern and not feel that pressure or stigma, I think we've really made some significant changes. And so I'd like to, that would be my ideal kind of situation. Again, lots of money, lots of support, and I think what would be necessary is really seeing lots of agencies, organizations working together, because I think what we see right now is there's lots of people working in silos, all doing great work, but not really working as a team.
And certainly that last point that you raised, I feel like is something that we can always handle and do a better job of, and that's getting out of our silos and talking to people in other organizations. DC is a small city. My director always says it's a compact city, right? There's no reason that we can't reach out and talk to each other. And I think, to be quite honest, over the last several years, certainly in my organization, I've noticed that we've been sitting at the table a lot more with OSSI, with DOH, with DYRS, with CJCC, with the OAG, with the Public Defender Service. So I'm hoping those kinds of relationships will continue to sustain throughout the future. The only thing I'll add to that is I think if we had all the money in the world, we could do a much better job in supporting communities, right? I think we see that a lot of these issues are not only kind of organic issues that are going on with our young people, but are really developed in part out of circumstance. And I think we could do a much better job really using the evidence that we have and using evidence that of programs that have been successful in other neighborhoods to go into communities in Washington, D.C. and really think about how to turn them around. So we don't have the numbers. You all don't have waiting lists. So the Child Guidance Clinic isn't backed up, has a book for months of kids who need psychological evaluations. So that would certainly be one of my hopes as well. With that said, I'm going to change the focus, even though I still have a couple of questions, but I want to make sure we get community questions in. So I'm going to start with, take the liberty and start with the probation officer. Ms. Tennant Bryant had a question in the back, please.
Yes, the question was for the wings that provided the services from birth to age 6. Actually, the question came just to us. How do you identify your population? And two, after the population is identified and the treatment plan is created, is there a way you transition them to the next phase once they've aged out to other agencies?
All great questions. So I think this system of care that we're working on, we're trying to answer all of those questions. I think they're identified currently through a variety of ways. I mean, I think that sometimes parents refer. PEACE, for example, the DBH program at Howard Road gets a lot of referrals from CFSA. So I think lots of times they're mandated. However, we're kind of working, one of my goals is to work on the other end of trying to educate and how do we identify when there is a concern so that we can intervene with an intervention. So I don't think, to answer your question, I don't think we're doing a very good job of that right now, of identifying. It's almost too late. It's almost like, obviously, they're not in the juvenile justice system yet, but the behavior has to be so severe. They're throwing chairs at school, they're getting, I know it sounds crazy to some people, but they're getting expelled from a child daycare center. They're, the behavior is so severe that that's when they are referred. So we're trying to do our work, on the front end so that we're doing better screening, we're doing better assessment so that we can get children and families into services when they're not so severe. And I think something too that I noted down that I want to make sure we note is not forget about all the kids who are internalizers. I think that, often the kids that get into treatment are the ones who are externalizing and are, in the classrooms doing kind of the disruptive behavior. There's also those kids who have traumatic experiences but are internalizers and, they aren't noticed as easily. And so we're working on that to try and make sure that we're not forgetting or that we're identifying. Does that answer your question?
It does, because the comment I have is that even though the population we service is older, I notice that a lot of the times the parent will express concerns about the younger ones in the household. And because they're exposed to some of the same behaviors that are displayed by the older ones, it may be a good idea to, even though the younger child is not involved in the court system, but just the family itself may receive a referral for that younger child who's screened before it escalates to the point where they're now in the juvenile.
Exactly. So we are trying to work with our sister agencies to exactly what you're talking about, to making sure that hopefully they are part of a family therapy. However, if they're not, or if there's other siblings who could benefit from additional resources, we're intervening as well. The other thing that we often hear too is that the parent knew something when they were younger, but again, they didn't know where the resources were, maybe there weren't resources, and so we're trying to prevent some of those cases.
And just to add to that, and I appreciate that dialogue, and that's the kind of dialogue that needs to occur in terms of making those connections, Ms. Tennant Bryant, with regard to our kids and their younger siblings and having a space for them. And I'll also say one of the evaluations that we do at the clinic that you heard me talk about today is a violence risk evaluation. So we're often asked, and I don't know if any of you all have seen our violence risk evaluations, but we're often asked by a judge, the judiciary, to to figure out what is this kid's likelihood of engaging in future violence or risk factors for violence. And what I frequently see in those evaluations is when we go back, and this is a lot of the times when we're doing the heavy lifting and really talking to parents about what was going on during that period of 0 to 4, 0 to 5. And that's when we find out that this is a young person who had been having problems very early on, right? They were the ones who were throwing the chairs in class. They were the ones who were biting the other kids, who were bullying the other 3-year-olds. So, you know, if we can, again, begin to engage those kids much earlier, then hopefully I don't have to see them later. More questions? Please.
I have a friend that does therapy with the sex traffic survivors and sex abuse survivors, and the youth are not at home, but she has to go into the home for home visits, and she has issues with a parent being on drugs or alcohol, and basically she can't accomplish anything. Is there some way to do that MPD can assist with this? I mean, you know, how do you deal with that?
All right.
Make sure I got your question right. So you're basically saying that when you come into a home, you're dealing with a mom who who have drug or alcohol issues?
Yes, she was telling me about it.
Well, we run into that a lot, and which goes back into me saying whether or not the family is ready for it. But I've also worked with families where the mom or the father has had alcohol issues, or they're drunk when they arrive to the home. Yeah. Ideally, what we'll do is if we already have the family and I can possibly work with them, then we'll refer them out to a service while I'm also doing family therapy. So it goes back into that whole engagement piece. I've worked with a mom who would not drink, she would not drink on the day she knew I was coming, which was enough for me to work with her to get to the point where she started to go to treatment like she was supposed to and address some of the issues that she needed to address. So a lot of times it's not necessarily about getting somebody to stop doing something, it's about getting them to access the help that they need to actually start moving in that direction.
Ms. Glover, and that's a wonderful response in terms of, you know, really just being able to meet people where they are. And I think that's some of the difficulty with this work, and you pointed out, you know, this idea of relentless engagement. And that's exactly what we need. I know that's what our probation officers do. I know that's what our managers do. This idea of relentlessly, you know, you're not going to stop, and you have to find some middle ground that allows you to do the things that you need to do, but also gives the client the agency that they deserve. More questions? Ms. Vanderbilt.
Thank you so much. I really enjoyed hearing from our young speaker.
Indeed, thank you.
Raidford. And I'm trying to remember, because we just got a lot of information after your presentation, but did you speak on how you were recruited, if you will, or, you know, how did you embrace and get to the position that you are with the youth council? And that's the first part of my question. And the second part is, have you utilized some of your own peer influences to get other kids to join in with you?
Well, for the first part of the question, how I for me, it was kind of the services that I was receiving, I realized that they weren't working for me, and I was at a point where something has to work. Like, I want to do things in life, and I need to get better. So I just, when the core service agency that I was receiving the services from, they asked me to go to this summit. So I was like, you know, okay. And at this summit, I just started like asking questions and wondering, okay, so why is this and why is that? And because of, I guess, my previous experience in the mental health system, I had ideas of how, you know, how I would think someone should be treated when they're receiving services. So that's kind of how I got introduced to the Youth Council. To answer your second question, I haven't really, I mean, of course, since I've graduated high school, I haven't really kind of met anybody yet who would, you know, want to I guess, be a part of the youth council or, engage in like services, but I'm always like, within the youth council, there is like multiple council members. I'm always trying to, encourage them, and there's kind of a, there's an air of it's okay to, have to deal with issues or, because everyone's human. So I kind of like continue to kind of put that, I guess, air out there. So, yeah.
Can you?
Yes.
Yes. You were fabulous. Too. I'd like to say that as well. You said something about doing presentations or something. How does that occur, or how could we, if I was interested in having a presentation done for some youth or
If I
buyers?
I can help Shanika out.
Okay.
Usually, as I said before, if individuals want youth voice, they usually contact DBH, and we would get one of the young adult allies, depending on what the subject matter is, to come out and speak to an individual. So it is through DBH that you would contact.
Okay. Thank you.
Mm-hmm.
Indeed, and Shanika, I want to, like everyone else, remark on, just how wonderful you were and how compelling your story is. I hope you'll continue this work and, be Dr. Raidford. A few years, I look up and I say, I remember her, because this is really, really important work that you're doing. Other questions?
How much imaging do you use, like brain imaging, to make a diagnosis?
Great question. Increasingly, we are finding ourselves asking those kinds of questions. I'm sorry. The question was, how often are we using brain imaging to make a diagnosis? And my response is, increasingly, we are using brain imaging. In fact, just Monday, I was at the office of a neurologist. I'll be back there tomorrow, having a conversation with her about working with our kids. We've had some difficulty, to be quite honest, as a city, being able to identify a neurologist who will work with our kids. But now we have one, and those are questions that unfortunately frequently go unanswered, that need to be answered more. And those questions obviously around neurology, around poisoning at birth, whether it be through lead poisoning, whether it be through toxins that children are exposed to during pregnancy. Lead is obviously a big one, which I said, and I'm thinking asbestos, that being another one with all these old buildings, and trauma. So I was actually just reading just before I came over here, about a young person who was in an accident after being chased by the police. And he was in an accident and had a traumatic brain injury as a result of that accident. And now we're attempting to adjudicate him for stealing the car. But the more robust issue at this point is the fact that the kid, corpus callosum, is bleeding, and you can't adjudicate the kid with a brain injury of that magnitude. So yes, so we are using that more frequently, and we recognize the importance of thinking about our young people holistically, who we're seeing. I'm not sure if I can speak for the others. I have a question then. Oh, there's another. Let me. You know what? I'm going to ask my question right quick.
Yeah, no, you can go first.
I can ask my question.
Yeah.
And this is less a question for me than I think it is a question that someone from the audience will be able to benefit from, and I certainly see it with my probation officers, or with our probation officers over at Court Social Services Division. How do you identify a young person who has a mental health disorder? And this isn't necessarily for us as clinicians, right? But for folks who are in the audience, probation officers, teachers, community members who don't quite know what's going on with a young person. What do you think, what would be some telltale signs that you could give a lay person to say, okay, this might be a person that, I should think about reaching out to, or, you know, consider for a probation officer a referral? How could you help folks out with that? Dr. Sullivan, you want to start?
I think for me, what we often, again, this is I kind of walk loosely on the fence because, again, I think especially there's so much stigma around mental health. But I think kind of my gut and my clinician hat is I really go on when there's a change in functioning. So if you're concerned about a child in a setting and they're not functioning and you're concerned about that to the point where you're bringing it to someone's attention, that's kind of a red flag for me. So when there's a change in functioning, whether at home, in the community, at school, you know, I think for me, again, I'm not going to necessarily, you know, obviously that doesn't mean that they have a mental health Axis 1 diagnosis, but again, I think that's where it raises it to a level for me. When someone, whether it's a parent, teacher, caregiver, sees a change in level of functioning, something that's different than before.
Excuse me. I'm going to have to agree with Dr. Sullivan. It is a change in functioning, but from what aspect, one might ask when you think of 16 to 25-year-olds, because they're going through their own changes as it is. But it's when those changes begin to impact those everyday things. So when we're no longer interested in school, when we're no longer interested in the things that just get us through our day-to-day. And I don't want to say the things that they were interested in before, because everybody matures and everyone grows up. But they're not interested in much of anything. And don't get me wrong, just because there's a change in functioning does not necessarily mean an individual has a mental health concern. But it is something that we need to be watchful of and see how it is impacting. Are they getting into more trouble? Is this an individual who was scoring high on tests and now is failing every subject? It's just something that we need to keep a watchful eye on. Sometimes it's not necessarily about a mental health issue, but it could be because of the environment. We talked about traumatic experiences. So it could be because of the environment, something they've seen, something they've experienced. And my biggest thing is everybody has a job, and to let everybody else do their job, right? So rather than somebody who is not in the field trying to make a diagnosis, if you see a change in functioning, refer them to somebody who could do an in-depth assessment.
And I agree with everyone that's spoken before. I think the only thing I would kind of add is the way we kind of look at it, especially doing family therapy, is when we go into a home and we're dealing with a family, we look at if there hasn't been any real environmental changes and there haven't been any changes outside of the household or inside of the household that impacted the child in a particular way, then that is a high alarm for concern. Because those, like she talked about with traumatic events or certain things that may have happened or anything that could have changed the functioning of the child, if none of those things are factors, then that is high concern that it may be something else that is outside of the child's control. And so when those things kind of come into place, that's my first kind of cue to kind of say, maybe we need to look into getting a mental health evaluation just to see, not necessarily to say that it is, but it's almost sometimes better to be safe than sorry later on, to kind of check it out.
Excellent. Yeah.
Can I add one thing to that we see family history?
Yeah.
Because from the time that a child is arrested and they're processed in our night intake at the youth service center, sometimes the parent will say, or what happened to what happened to the father, or what's going on, and a parent, or some parents will say, I'm on medication. I know these kids drive me crazy. I'm on medication myself. Right, and so those things like that, and that's the good point to, because it's a report of family history of mental health is where we find ourselves.
Definitely agree.
Exactly, and I'll just add, Actually, I won't add. I'm seeing Shanika over here. Why don't I let you add, and then I'll come in. Go ahead.
I was just to actually like recognize some of the changes that, you know, everyone was saying. And I was thinking in school, because that's where most of their time is spent. It takes someone to actually, look and see, they may not have always been getting the best grades. Maybe they've been staying, at a steady level, but to still, notice some changes or some, just notice how kids are. And I was the type that, I was getting high grades and then I started getting lower grades. So just knowing those changes, and maybe changes in mood, it might not necessarily be, in like school, like scholastic or, things of that nature, but just kind of noticing those. And when you do notice those, build a rapport, with like the child or student so that they'll be more comfortable in telling you, certain things, and then you can refer to, other services.
Excellent advice. Excellent advice. And I'll just add for those of you all in the audience, don't be afraid to be the one to make the call or to give the referral, or even just to call and try and figure out and say, hey, Dr. such and such, or hey, whoever that mental health worker is, I was talking to, this child and I was a little bit concerned. When you get a moment, can you come talk to him? Or can you tell me what I should say, or something like that, because that matters, right? And in a lot of these cases, you all may be the only one, right, to be the person to, follow up and make sure that question, that concern that you have is addressed for that young person, especially as we start talking about stigma and things of that nature where young people may feel ashamed. Anybody, not young people, adults, feel ashamed about what's going on with their mental health. But it's so important that these issues are addressed. With that said, take one last question. It's probably about time to have Ms. Van come back up. So, last question.
Hi, I'd like to circle back to something that you actually mentioned during your presentation, which is you discussed racial and ethnic disparities, or how do they racially identify when you have young people come through the court. And so, in thinking about particularly the more systemic grant-funded work, what any kind of outreach is going to, like, for example, the schools, the people who work with the kids to recognize the difference between a manifestation of a mental health crisis and not taking that manifestation and criminalizing it. So they shouldn't necessarily have to go through you to get services. And so we know that there have been multiple studies that show that when it's kids of color, the behavior is criminalized and it's seen as something that's internally wrong with them. But when it's not kids of color, it's externalized and they're seen as having potential to work stuff out. So if we're looking at it from a systemic perspective, like you mentioned during your presentation, what kind of outreach to those frontline workers, those people who might make the report, to recognize that, no, this is not criminogenic. Yeah. This is actually something else. Is that a part of the grant outreach? I'm just curious.
For our time, it is. When we do training that includes everyone. Other workers, community members. We have a few trainings coming up. I think we just recently did child exploitation training, sex exploitation training. And invited not just DBH workers, but community members as well, for just that reason, to try and, I don't want to say normalize the behavior, but to make sure that individuals have a better understanding.
Right, like understanding that girls are often running away from something,
right.
So they shouldn't necessarily be treated as a status offender. We need to do a recall analysis to understand what it is they're running away from so we can protect them. Very groovy, okay.
And I think some of that thinking is happening, certainly around, as the last point you mentioned, young people who are running away. Obviously, there's a new bill out there that, really pushes against criminalizing status offenders, right? And that status offenders can't be detained any longer. So some of that thinking is happening. I still think we need to do a much better job on issues around race and culture. I think those statistics are very clear that, you know, Black children, African American children are criminalized in this, not only in this city, but just in general. But I don't think there's any other way to interpret, you know, 96% of young people who walk through our doors are African American. And I think that's an area where there's a lot more work that needs to be done, not only in terms of mental health, but just in general. With that said, thank you.
Thank you. Let's give our panel. Thank you all for sticking it out until the end of today. We're almost at 4 o'clock. I truly appreciate our panel. Thank you again. Thank you, Shanicia, for sharing your story, for sharing your insight. We truly appreciate and value that. Wishing you the best of luck with everything you decide to do. Last 2 housekeeping things, please fill out your feedback forms. If you are here for continuing education units, please sign out so you can get your CEUs. NASW requires you to sign in and sign out. So don't blame me if you don't sign out and don't get your CEUs. It is not Diamond. It is an NASW requirement. Then lastly, we have 2 upcoming events for CJCC that will have CEUs. One of which is the Criminal Justice Summit, which will be in March. Please look out for that. I think it's the middle of March. I don't remember the exact date, but you will be getting a save the date soon. We will also have the Juvenile Justice Summit in August. I'm thinking August the 8th or 9th, which you'll get something for that as well. And we will have a spring technical assistance training, which we have not decided yet, so hopefully your feedback will allow me to decide what we'll be talking about. Thank you. Have a good one. Bye.